CDC something, right? Research, right? The current statistic based on kids born in 2008. Born in 88.
I have to go back and look. Yes, I think.
So in other words, you can't diagnose it for. So I was looking at this just the other day, but I could be wrong. But since you can't diagnose it first, there's some lag time, obviously, so you can come up with the statistic that 1 in 88.
Right. So what the data is based on children who are 8 years old.
Okay.
And so and what I can't remember off the top of my head right now is the 1 in 88. I think it's 2010. That's what I was doing. So we're coming up with the same number too. It's 2010 data. And so in fact, I know that I have lots of colleagues right now that are working on the next iteration, which will be the 2012 data. So that will be coming out in the next probably 6 months or so. But you're right, it's looking at 8-year-olds. And so there is a delay in sort of what is reported. The difference is they are now looking, also there's a subset where they're looking at 4-year-olds, and then there's some work being done to look at if you have a diagnosis at 4, or do you still have that diagnosis at 8?
I don't know if you want to try to read the rest.
No, I'd rather have you say it.
There's sort of two things. If you have a lag time until you can present that statistic, and then also the DSM-4 has changed to the DSM-5, and I'm not sure what criteria you're using to say 1 in 8 is diagnosed with autism. So my question is, how do you see that affecting the statistics? Is that going to provide upward pressure or downward pressure, and how significant is that if your criteria changing to match the DSM-4, or are they staying?
So it's a really good question. And so what happens when they're doing, and I'll say this really briefly, but what happens is when they are looking through the data to decide that a child has an autism spectrum disorder and is going to be counted in those prevalence numbers, they look at medical records, they look at educational records, and this is happening in a number of different states across the country. And they also, every single child that's identified through that process, there's a clinical review that happens. So somebody who diagnoses autism on a regular basis does a clinical review. And so there is a clinical review and a clinical determination that a child has an autism spectrum disorder. So it is possible and that a child may not have had an autism spectrum diagnosis and a medical record, but was found in the educational record. So it's an independent review where they use criteria. But they are looking at DSM-4 and DSM-5 to see if it's going to make a difference. And I mean, part of it is we're just going to have to wait and see, but they're very actively looking at the changes and how that will affect the prevalence. So the criteria they've been using to identify children has remained the same in each of those study years.
Anybody else want to comment? Seems that's pretty much your question, Georgina. Everybody's saying no, thank you. Let's see. These are great questions, by the way. You guys did a very nice job. This one's from Christina Mahoney. Christina, raise your hand. How do other countries or cultures view ASD? What services are available in other countries, India, Africa, etc.? Interesting question. Whoever wants to take that one, we'll pass the mic.
I can say just a little bit. If people are really interested in sort of the anthropologic or looking at how autism is perceived in different cultures throughout the world, there's a really good book called Unstrange Minds. It's written by an anthropologist at George Washington. And he went sort of around the world and looked at children with autism, or they may not all be children, but people with autism throughout the world, and describe the different contexts within which they live. I don't know what the other part of the question was.
what services are available in other countries, or is it similar to what we have? Do they have more services in other countries?
It totally varies. I mean, it's probably in Europe, the services are pretty similar, maybe in Australia, and then I think in my experience in talking with developmental pediatricians like in India and in Turkey and things like that, there's in some places really, really good services, in some places not good. And I mean, sort of similar to here in the United States. I think there are certainly areas where there's a wealth of services and areas where there aren't. Just wanted to point out that Christine is the social worker in our Good Samaritan Clinic as well.
I would only say that it is not unusual for a parent to contact the school system and we find out that they moved to the United States for educational services for their student with autism specifically, and to Atlanta specifically for those educational services.
Really?
Yeah.
Any kind of follow-up, Christine?
I mean, this morning I met with a family from Bangladesh, and the child is 12 now, and he has pretty severe autism, and the dad showed me paperwork from where he was seen in India, and he went to Autism Welfare Foundation, and received all these services, and it was really great, and they moved here, and I'm not sure why they moved here, but now we're having a really hard time in the school system. You can't even get insurance. So it's kind of thrown them backwards instead of forward. So.
Marcus is doing some work with I don't know if this person is a refugee, but with the refugee services clinic. And so Marcus might be one resource. But I would also connect with the school district with this, which you know.
Okay, next question is from Mary Vincent. Mary, where are you? Okay. How is the Marcus Center attempting to reduce the significant waiting list for an evaluation? How are you partnering with floor time? Which I don't know what floor time is here. Somebody like this.
You were right. You really hold it right here.
Yeah.
So yes, there is a significant waiting list at Marcus. It's sort of a well-known fact. However, the waiting list is less than it used to be, which is of no consolation for those people who are waiting. One of the things that we know for sure is that while we would like to see every child and do a good job, we are not the only people who can do a good job. And we feel like it makes no sense for us to continue to try to see all the children through our doors. We need to see the children that can't be seen anywhere else. So one of the solutions that we have come up with is, one, research. Research has done a really good job. You know, the wonderful thing about research is if you're willing to engage in a paradigm, and for the paradigms we're running, most of them are eye tracking, which I didn't show you a video of this, but this is not an invasive procedure. You sit, you watch a video, they track where your eyes are tracking. It is not that invasive, and children get an evaluation. So we have 4 or 5 different studies that are going on that children would be able to come through, be a part of research, and they would also be getting evaluations. So these are children who get follow-up evaluations, but we have infants and toddlers who are getting evaluations for the very first time in this mechanism. So that's one way in which we've been able to reduce the waiting list. Another way that we've been able to reduce the diagnostic waiting list is beginning to put together communities of learning. And this is something I feel very passionate about. I feel like there are plenty of people around the state of Georgia who do a really nice job assessing people with autism, but they don't have a lot of support. There are 1 or 2 of them in any given community, or there's a lot of people in the metro area who might like to be part of a community of diagnosticians who can share fidelity around the ADOS and make sure that we're all seeing things in the same way. Of the children who come to Marcus, we overturn about 40% of those diagnoses because children don't actually have autism. That's not what we're seeing. So we'd like to be out of that business of overturning diagnoses. We like people to be seeing things autism in the same way. In terms of treatment, that's a tough one. You know, we have long waiting lists for feeding programs, for severe behaviors, and we just have a lot of specialists. That's what they do, and this is a very labor-intensive process to get these kids in. And as many of you know, it is not something that is easily paid for. So it's hard to get kids in on Medicaid dollars, but we're doing it through philanthropy. I think that we don't have one great answer to your question about how we're reducing the waiting list. We've looked at multiple ways of bringing the waiting list down and making sure that children are connected. Part of care coordination is that as well. That if a family is waiting for a few months, that they're also getting a call from our care coordinators, and they're able to tell them, okay, so have you gone to parent? Have you looked into this? Have you connected with Babies Can't Wait? Have you done these things? So that there are things that they're getting in the meantime. In terms of floor time, we have very warm relationships with, and then I say we, I'm speaking for Marcus. So keep in mind, we have a whole group of folks who are developmentalists. We have a whole group of folks who are very strict behaviorists. And I would say that there are many professionals on the staff who have warm relationships with floor time. We see this as a part of a continuum. There's developmental interventions, there's behavioral interventions, and there's everything in between.
Floor time is.
Floor time is, is a more developmental approach, Stanley Greenspan, and it's, I think if you ask the behaviors, they would say it's exactly opposite of what they do. I don't entirely think that's true. What I think is it's more developmental. It's more about meeting the child where they are and scaffolding skills up. Whereas behaviorism obviously is looking for how are we going to increase or decrease wanted or unwanted behaviors. Does that answer your question?
I just want to reiterate something that Jennifer said. It is important for families to have a diagnosis. It makes a big difference just to know what's going on with your child. But waiting for that diagnosis doesn't mean the child can't continue to get services. So it is important to recognize that the child has developmental needs, whatever those needs are. And even without a diagnosis, if you know there's a developmental needs, they can continue down the process of getting those needs addressed while they're waiting for that diagnosis, whenever that is.
Great, well, sort of in a similar vein, there's David Waters has a question. Are there any blood tests or genetic tests that can be done that will definitely indicate that a child may have autism? Who wants that one?
So right now there's two ways to look at that question. There's not a blood test that identifies a child with autism. However, the flip side of that is there are certain children with certain genetic conditions that we could identify through a blood test who might have an increased risk of having autism. For example, there is, compared to the general population, in Fragile X or in Down syndrome, we see a higher percentage of children with either Fragile X or Down syndrome that have autism, but not everybody with that genetic disorder has autism. So blood tests and lab work, as well as imaging, brain imaging, can give us sort of clues that a child may be at higher risk for autism, but there's nothing that we can look at in the blood or in an MRI or something like that would diagnose a child with autism.
David, do you have a follow-up?
Well, just in that vein then, how do we, I can understand then how long this process takes to identify that this child is autistic or is not autistic, and even in there, where they fall on the spectrum. And I'm just trying to think, is there any effort going on to really come up with something that would be more definitive, from a gene study standpoint or anything else? Because, the kid could be inactive. My thought is from a family standpoint, family dynamic standpoint, and that points to the fact that you're saying it's identified so late. How much of it is that child being in the environment they are, where maybe there's not a lot of reading taking place, maybe there's not a lot of talking taking place, and how is that affecting their behavior when they get to school, as opposed to that they really do have some other type of more deep-seated problem. Does that make sense?
So, I referenced the Nature paper when I was speaking, and so let me just be more explicit about what that was. At the Marcus Autism Center, one of the technologies that they began looking at Yale and they brought with them was eye tracking technology. And the eye tracking technology there is really nice evidence, the Nature paper is the most recent, that suggests that as early as 6 months, we begin to see the way children look at the human face different for children who have autism than children who are typical. And so these children have been put into a paradigm where they have watched videos of caregivers talking to them at 1, 2, 3, 4, 5, 6 months, 9 months, 12 months, 15 months, all the way to 36 months. These children have been clinically characterized. So as they've gone through the process, we have eye tracking patterns for them, where they look at the human face, the eyes, the mouth, the body, or objects behind. What's really profound about this is it's been replicated that by 6 months of age, we know that children who are typical will pay an inordinate amount of attention to the eyes. The eyes are the window to the soul. Children are coming into the world ready to socially engage. And about 9 to 24 months, they're paying a little more attention to the mouth. Why? Because they're learning language. Children who are developing autism, they begin very quickly to stop paying attention to the eyes. They pay much more attention to the mouth, probably because it's movement, not because it's language. And much more attention to the body and movements of the body and objects behind. And that this is looking like a potential screening result that may help us in the future with screening and diagnosis. It's very preliminary science. So the next question would be, well, what are you going to do with that? Well, there really are projects in place to put the eye tracker into a form that it could, in fact, be a diagnostic test. And that is down the line. You will be hearing more and more, I think, about that. There's a lot of investment on the part of looking at that and seeing whether that is a reasonable way for us to look at social growth charts. You know, if you go to the doctor and you know your child's head circumference is where it should be and their height and weight is where it should be, soon we hope to be able to plot social growth charts. So you'll really, through the eye tracking technology, know whether your child is following the trajectory we hope they're going to follow if they're typical. And if they're falling off that trajectory, then imagine the kind of things we can do by helping parents to know what to do in the environment if we're seeing risk flags as well earlier than you can clinically see it with the human eye.
Great, thank you.
Fascinating. This one is from John Jenkins. There you are. Hey. His question is, autism appears to get treated more as a medical problem, not the fault of the child. If I get this question wrong, there's like an arrow in the middle of it. No. Okay. How can we adapt a similar approach for other disorders like ADHD, conduct disorder, bipolar disorder, psychosis? And this is a question I feel like many people on this panel can speak to. Is the stigma of autism?
It seems like there's less stigma in autism than other disorders. And how have you turned it around? Well, I think we'll have other things.
I wouldn't necessarily say that there's less stigma of autism, because I'll tell you that most parents do not want to hear that word autism. Even if I told every newborn parent, and maybe you would disagree with me, but I think if you told every parent, if we see signs of autism, we want to tell you right away, so there's something we can do about changing the trajectory of your child's potential, I still think they don't want to hear the word autism.
But I think what he's saying is that kids who have ADHD, even though that's a neurological issue also, really it becomes more about what the child is doing as opposed to the effects of that disorder and what we can do to support. And I have nothing really to add to that. I just think that kind of clarifies, because I agree with you. We know ADHD is not, it is neurological, but yet we treat it as if it is bad behavior on the child's part. And I think that because autism has had such a long history of a medical diagnosis in a different way from ADHD, for example, I think that that's probably part of that.
I think that in the school system, that's one of our charges, is to try to change the mindset of staff who may not be aware of what the characteristics of autism are and are just looking at sometimes behavior as bad behavior or discipline-oriented type of behavior. And that's something that we work with our discipline department as well very closely on. I also think that we see in the school system an emergence of comorbid types of disorders that are certainly starting to be more and more prevalent, like autism. Many times, as probably all of you know, ADHD, OCD are part and parcel of that disorder, but other things like bipolar disorder, all kind of
in a kind of a muddy, area together. So, I don't know, maybe some of our co-panelists can talk a little bit about that, but that's what we're seeing a lot more of in the school system as well.
Anybody want to read? Wrapped up, okay. Just hang on to it, we'll see who's next. Let's see, there's so many questions and they're all like all over the place. Well, since the Fulton County folks have this microphone on and then lots of this is from, is it Clayton Adams?
Yes.
To Mary's, where are you, Clayton? How many schools or teachers receive ASD training through Fulton County's internal training program? How does the district decide what schools receive this training? And I'm going to add to that is moderator's prerogative, is okay, and is this, would you say, common across Georgia in these terms of percentages or ranges, or does it vary system to system?
I don't know.
It varies.
It probably varies. We have, every single special education teacher has to have training in autistic spectrum disorders if they are highly certified. So in terms of more specialized training, we do offer trainings every single semester during pre-planning, sometimes during post-planning, and throughout the year. We offer it to all special education teachers as well as general education teachers who are in a co-taught setting and need to know as well. Administrators also come to those trainings. And as far as an actual number who have attended our trainings, and they are on the increase because of the increase that we see of autism in our schools. So I would say probably a very large percentage of our teachers have been trained. We've also trained instructional support teachers who are school-based facilitators and paraprofessionals as well in autistic spectrum disorders and behavior management, all of those things that go along with it. And those ISTs, as we call them, instructional support teachers, are at the school-based level, and they're there also to support and to provide day-to-day training for teachers sort of on an ad hoc basis when needed in the schools. We have behavior interventionists who also provide a lot of those trainings, but also work with individual schools depending on where the need is.
And I will say, they do, the different departments that do the training do keep a database of who they have trained, but we're not part of those groups that do that training and maintain that database. So for example, my assistive technology folks, we know every person in the district that's been trained on PECs. We know, I can pull it up. I just don't have those numbers, to share off the top of my head.
So if I could just ask a little bit more about that. So if I understand that right, it's kind of a voluntary thing and it's offered at the central office, your central office. It's not actually, those trainings aren't offered in local schools.
They can be. And that's generally by the request of the building principal or the special education department in the school, but the trainers will go. We also have some very basic Autism 101, if you will, PowerPoints that can be delivered during a full faculty meeting at a school. And then other more specialized trainings, like I was mentioning, the PECS training, for example, that I do, that's something that individuals show an interest in, and we do it centrally, and it's done essentially voluntarily. They're not required to do it. What's the question?
I wanted just to kind of add, my name is Tony Jordan, but during the training, are there parents who have kids with a diagnosis involved in the training aspect? Parents meaning who seem to have a successful track record, or at least the child is growing in a positive direction of the parents involved. And that's the reason why I'm here. I have an 11-year-old son who's diagnosed with autism. I just moved here from Savannah, Georgia, and I am super proactive with my child. We've been in the Babies Can't Wait, we've been to the Marcus Autism Center. Prior to moving here, I contacted him a year ago. So I'm really plugged in, but I'm here because I'm having some success. My wife and I are having success with my child. And I figured the one thing that I can do, if I can't do anything, right, is to offer what's working for us, and maybe it could help, across the board. I don't know, I know that there's a strand a parent to offer that. And I apologize.
That's a really great contribution, and I think up until now, we've mostly been focusing on what happens in the classroom versus what happens at home. However, a parent myself, I know that you and I both have a lot to offer in terms of our own children and what works with them. And I would say that every single IEP team works very closely with parents all throughout the year to determine what is working best at home. We collaborate with parents every day in terms of, you know, what might work in the classroom, what kind of reinforcers might a student need. Those conversations are happening all the time. As far as training goes, I think that's a good idea to consider, you know, and I'll take that back to our coordinator team. Just, you know, so how can we better involve parents in our teacher trainings as well if there's an opportunity for that. So thank you.
But the flip side of that is we do invite parents to our trainings. For example, our assistive technology course catalog, parents are invited to participate in that as participants, not as presenters currently, but as participants.
Okay, next question. This is from Stephanie Owens. Stephanie, raise your hand. I understand that there have been significant programmatic changes to Babies Can't Wait. Can these be described to include OT, PT, and ST services provided in the home?
I guess that's me.
Yep. I'm trying to mix it up too much.
Yes, we are making a lot of changes to the program, and I can't necessarily say we're done. You know, we took a step back and decided we needed to reevaluate what the program looked like. We have been faced with financial challenges. You know, there's less federal dollars coming down to help support these efforts. There's less funding, reimbursement through insurance companies. All those kinds of things are really impacting our ability to deliver services. We are looking at our diagnoses to know what kinds of kids are eligible for the program. And I would say Georgia has probably a more restrictive diagnoses eligibility requirements than many other states do. But we are looking at that, and I think, you know, we will continue to have providers, speech, OT, PT. The challenge again is we don't have all those providers in all parts of the state. So we have special instructors who can work with families. We have abilities to reach out to those types of providers because the way we work with families now is through a primary service provider model. So we evaluate the child, determine what the child's primary need is, and we try to work with that child on that primary need. So the provider is somewhat specialized in that primary need. Now, most kids aren't going to have just one need. They have lots of needs. So that primary service provider has the backing of a team. So that service provider who works with that family comes back and works with a team. They discuss the cases. They talk about the child's needs. And so if I'm a physical therapist and I see that the child has other needs, when I go back to the team includes a speech therapist, includes an occupational. So I'm getting the benefit of, that family's getting the benefit of a whole team of folks, even though they're primarily working with one individual. So we are looking at that. We are looking at telemedicine. Is there an opportunity to use telemedicine? Now, we do provide services in the natural environment, so in most cases that's in the home. And the whole concept of natural, or in the child care, depending where the child spends most of their time. So the whole idea behind the natural environment is we want to make sure that we're addressing the needs of the child where they spend the most time. So if the child came to the clinic and they are in a room with toys, but at home they have stairs. So how is it that you're going to provide those services in the clinic when it's not the same as what they need? So we do try to provide in the natural environment. What that means in a lot of parts of the state, we're going into very rural areas. We're going places where it takes a long time to get there. We're going places where they don't have good internet access or ability to use Wi-Fi or other kinds of things. So there are challenges with that. We are working right now and coming up with potential models of how we move forward. We're looking at what other states are doing. We have folks from our public health system from our different districts. We have some providers all working together to kind of look at what does the reimbursement model look like, what are some creative ways to improve finance for the program, for families who are participating in the program. We're looking at a separate issue of service delivery. Are there different ways to deliver services? Are there creative ways we can consider so that we can provide more access to families? So it's an evolving process. I think the program has been going on for a very long time, and as the world has changed around the program, we are now just trying to figure out how to keep up with those changes. And rather than waiting for the next change to come to say, oh, now what do we do? We're trying to anticipate in the next 10 years, 5 years at least, what are the different potential things. So if right now we can do this, what if something changed? What's our next step? So that we can at least outline those steps rather than waiting for that to happen and then be very reactive and thinking about what do we do next. The collaborations are incredibly important, working with the school system, working with DECAL, working with the Market Center, the CDC. We're all trying to get to the same kind of thing. So learning from each other has been very helpful. And again, talking about how we work not only with the family, but with providers to help them learn different ways of providing services. And I think the gentleman mentioned earlier about, in the home, kids who are diagnosed with developmental delay or autism or who have no diagnosis at all, how do we work with families to make sure they understand the importance of engaging their child, the importance of speaking to their child, the importance of reading to their child? All those kinds of things make an impact on that child as well, whether they have a developmental delay or not. So we're really, I think collectively, are all working towards how do we help engage families more so they can get the best opportunities for their child.
Any follow-up?
In an ideal world, I love ideal.
Yes, let's talk about
that. How would you like to see it? And when you talk about major changes, are you talking about the major changes in the financial capacity, or are you talking more about major changes in diagnostic or other?
Yeah, it's across the board. In the ideal world, we would want to make sure every child who has any concerns about developmental issues, whether the parent just notices something that's not quite right, or whether it's an official diagnosis from the pediatrician or whatever the case may be, that every child has an opportunity to get some support to enhance their abilities. That's the ideal world. We can't service all the children. So that's why we have to look at not only do babies can't wait, but other ways that children can get those services. Sometimes it's through community resources, sometimes it's through the child care provider, sometimes it's through other means. So I think we have to continue to make the most of the situation we have.
Yes. We know that our child care, early childhood educators are not going to be able to do the things that a therapist would do, but we feel that by preparing them to understand what good strategies are to use, that those can be hours of engagement also. So I can't remember how many hours of engagement they talk about being important for a young child with autism.
25 hours.
Right, but I know that Georgia can't afford that in today's Can't Wait program. And so, yes, we need those therapists, but we also really need our early childhood educators to understand how to support those kids so that we can, and those children who maybe don't qualify for early intervention, but do have developmental concerns, so.
Okay, we are getting down towards 4 o'clock, and we've got still a hunk of great questions. So I'm going to encourage all of you guys, if I don't get to your question, please feel free, if the panelists are okay with approaching them maybe after the 4 o'clock hour. But I'm going to burn through these like speed answer. Okay, I'm going to try and squish 3 more in. And none of them are really short answers, but we're going to pretend like they are in the ideal world. This one is from Deanna Karen.
Oh.
Shoot. How do you say it?
Hi. Yep.
That's it. Okay, I'm going faster. What do you think of the Yale research regarding abnormal placental folds and the link with autism spectrum disorders?
I have no idea.
It was an interesting finding, and you may know about it, but it was a researcher that does some malpractice, professional witnessing, and happened to discover on a couple of cases when he was researching for these children who were seeking, financial judgments in the legal system, that there were abnormal placental folds. And it happened that one of his coworkers who works with children with autism had a baby and thought she would just have her placenta examined. And it turned out her placenta had abnormal folds, and indeed, the child started showing symptoms of autism fairly early on. And so they addressed them immediately. And so she's become a huge advocate. But I haven't heard anything. This was released, I think, maybe in September was the first thing I saw of it. And it came through, some medical online thing that I got. But I haven't heard a word since. So I thought, well, was it just a bogus finding?
Now I'm really curious, and I'm gonna go back and look. But I wonder, we've been hearing a lot. I mean, if you've been listening to the news, you've been hearing children who have fathers who are a little older, children who have mothers who are at risk for diabetes or who are overweight or obese. There's like a higher risk. So there are lots of risk factors, I think, and we're really just in that place where in fact, it could be the case that a certain number of children, that is the case. I don't know if we put our high hopes in finding the thing. Because I don't think, given the heterogeneity of autism, and I don't think given how many different risk factors we see, that we're going to find the thing. And so then, I don't know, I personally just get a little worried that we then go on this wild goose chase after every single little risk factor. And so it's a balancing act.
Yeah.
But I don't know that I can't comment on that particular research.
Well, I guess just to sort of add on that same vein, the idea, when we think about sort of other medical diagnoses, like heart disease, for example, what has happened over the years is we've ended up coming up with a list that says you're at higher risk if you have these things, you're at even higher risk if you have these things, but you're pretty low risk if you have these things. And I think we will get to, and some of those will be biologic things, like what you're talking about, and some of them will be, familial risk factors, like someone else in the family that has autism, or a father or a cousin or something like that. And so that may be one thing among many that will fall out, and I think there will be in the next, I shouldn't predict, but 5 to 10 years, we will have a lot better idea, I think, about what risk factors are. And the important thing about, I think, risk factors is that means that if we see a child that is at risk, or a family that's at risk, then let's pay attention a little more. Let's intervene a little earlier and things like that. So those studies are all important, but I think they're important putting them all together.
Thank you.
Okay, we still have 2 minutes. Are you guys still good? And thank you guys. This is from A. Reeves. Hi. With the DSM-V changes as well as policy changes for insurance benefits, what are the potential changes for new ASD diagnoses? Do you expect an increase or decrease, and how might services be affected? Opportunity knocks. Anybody have an idea or an answer?
I think, part of this is we're just going to have to wait and see. I think that there are people that have been looking. Kathy Lord has looked, done some publishing, and I don't remember the details of some of the stuff that she's done, where they have looked at sort of the effect of what's going to happen to diagnosis with the change. The basic prediction is that there's minimal. They think there's not going to be a whole bunch of change between DSM-4 and DSM-5. There may be some individual children that may move within that diagnosis, but I think part of it is I don't know, I think it's a wait and see.
And part of the DSM-5 is that if you currently have a diagnosis from the DSM-4-TR, you will retain that diagnosis. You should not have your diagnosis taken away. I won't say you won't. You should not. That is not what is written in the Diagnostic and Statistical Manual. So, but yeah, I think the worry was that individuals who are getting services, who had a diagnosis, would then have it ripped away, and that it's explicitly addressed in the DSM.